All right. Thanks, everybody, for joining us. I'm Dr. Jeff Brown with my co-host, Dr. Jeff Cole. I am joined today by the CEO of Silver Bullet, Paul Chirico. Silver Bullet is developing the OrthoFuzIon bone screw system with an antimicrobial coating based on proprietary silver ionization technology designed to prevent contaminations associated with medical device implants. This is one of the coolest things I think I've seen in quite a long time. I think it's going to revolutionize not just orthopedics, but all types of implanted devices across the medical chasm there. Paul, thanks so much for joining us. Tell us about Silver Bullet.
Well, thank you very much. Something I enjoy talking about. Silver Bullet Therapeutics is about a 10-year-old company. It was founded with the classic three steps of the stool, or three legs of the stool. We have a clinician, Dr. Bowden Chopko. He's a practicing neurosurgeon. He's assistant chief of neurosurgery for Ohio Health. We have a scientist, Houdin Denad. Dr. Denad graduated from University of Minnesota, where he did his thesis work in the use of silver as an anti-germicidal. And I've been in the industry for a little over 40 years, started in pharmaceuticals, did my infectious disease preceptorship program at Duke University. This is my third company that I've been a founder of. And we have decided that although surgery, and we make improvements on surgical instrumentation on a regular basis, the one thing that continues to undo surgery is infection. And we learned during COVID that you just can't protect everybody with rising viruses, infections, bacteria. And one thing that threatens surgery today is a bacterium that shows up that's resistant to any antibiotics. So looking at implants as we move forward, and we're all implant type people that are associated with the company, we started looking at how can we make surgery safer and where's the big market opportunities. And that is when you take a simple product like a bone screw. There really hasn't been much improvement on bone screws for 50, 60 years since it went to a locking screw. Other than that, they're the same screws that we've been using for a long, long time. So we take a titanium bone screw, and what we do is now we coat it with silver and platinum. Silver and platinum we've figured out from the semiconductor industry. We're located in San Jose, California. So borrowing from the semiconductor industry, we borrowed the concept of sputtering. And sputtering allows us to put in the same plane silver and platinum. Silver being a less noble metal than platinum, platinum acts as a catalyst, causing the silver to rapidly corrode off, and silver ions protect the device from infection. And in some respects, our original studies that we performed in rabbits, we actually eliminated the infection with no concurrent antibiotics.
Is that right?
So it was quite an amazing accomplishment. I mean, silver's been around for a long time, hundreds of years, but it's not the amount of silver that you put on. Silver by itself just isn't that good as an anti-germicidal. It has to be converted to the ionic phase. So you have to steal an electron. And when we talk about the amount of silver and platinum we put on, we measure things in the worlds of angstroms. So
wow,
it's quite a bit different thinking. Our product has been used in patients for dental implants. We've done studies on both pacemakers and defibrillators, and we have an approved product in Europe right now with a reduction of infection claim for orthopedic bone screws.
that's great. And you mentioned antibiotic resistance. Is the theory that your product will kill anything that's bacteria?
You know something? We have
strain?
absolutely. So we have tested it on just about every bacterium that we can find. Several years ago, we tested our product against the top 6 CDC superbugs. We did those in a third-party laboratory, Emory Labs in San Francisco, and they found that not only did we completely eradicate the bacteria after 24 hours, and these were using 4 millimeter by 10 millimeter titanium coated screws. So not a disc or a device. It's designed for working across all bacteria. And so not only did we eradicate the bacteria, but we washed the screws and put them back into fresh media and determined that they completely eradicated the biofilm as well. So our product, the nice thing about silver is there's two modes of activity, cell wall and also works on protein synthesis. So as a result, this is one reason why you have not had resistance reported against silver over the years.
Because it's got two mechanisms, you're saying?
Yes.
Yeah.
And you think about it, when you were going through your training, you probably all rotated through some type of burn center or saw this type of patients. And those patients, you know, you would take on 1/8 of an inch to 1/4 of an inch of silver sulfadiazine.
Yeah.
And I mean, quite amazing when you think about that was used or still used to this day, and there's not resistance reported to it.
That's right. Oh, I saw, of course, I've seen your pitch deck, and I saw the discs, the auger with the plated versus the non-plated, and it's just, I mean, you got me as soon as I see this thing. It's amazing. And I don't know if the public understands how big a problem an infection is in a screw or anywhere in the body. You know, the screw doesn't have natural immunity, right? But your bone does. So once you put a foreign object in, it's always a risk. And it's funny. I know that this works on a lot of things. I've got an ionizer on my pool. Did you know this, Jeff?
I didn't know that.
So I can run a low chlorine amount in my pool because it leaks metal ions into my pool. I think they're copper, but they might be some silver as well. But it works. It keeps the algae growth down, so it inhibits microbial growth in a 26,000 gallon pool. I guess when I'm thinking about the screw, though, Paul, like questions that come to mind is like, you guys must have the perfect amount so that it doesn't leach out and you look like a Smurf, but that it doesn't chip off, it stays. Do you know how long it will stay on, and how can you tell us how you determine the right amount, or is that proprietary?
You know, it's somewhat proprietary,
Right.
and that is, you know, when we first developed the company, we relied on the traditional methods of plating silver onto a device, and this is using a bath.
Mm-hmm.
So literally, you put just like a fork and a knife. You put it in, you electrically charge, the silver attracts to the instrument or the device, and then you create a coating. But the problem with that is you create a layer. And so you create a layer of silver, and then if you want to put platinum on, then you have to create a layer of platinum. And in the bath, there's all the impurities that build up over time. It took us years to develop the sputtering concept. And the reason for it is sputtering is relatively unknown in the area of medical. And so in this case, we take a titanium device, and titanium is an amazing metal by itself in the fact that it's self-healing. It has a titanium oxide coating. So if you get a scratch across the titanium oxide coating exposed to oxygen immediately forms and seals off the crack that you have in titanium. Well, the titanium oxide coating also is a barrier for anything that you want to attach to the titanium. So what we do is we take a screw, we put it in an oxygen-free environment, a sputtering chamber. We literally pull down 10 to the -5, 10 to the -6 atmospheres, where outer space is 10 to the -9, to give you as an example. And so we pull down 10 to the -6 atmospheres, and then at that point in time, we etch it to take the titanium oxide coating. Well, with no oxygen involved, now you have free titanium. And at that point in time, you then co-sputter it with silver and platinum. The free titanium is looking to bond to anything it sees. And then the first thing it sees is silver and platinum. So the bonding is incredible. So we picked the toughest market first, bone screws. It sounds relatively simple, but when you think about it, a bone screw has to go through the abrasive forces or hold up to the abrasive forces of bone, which is unlike wood. It's much, much harder. And so if you're putting a coating on, if you're putting off a soft coating, an antibiotic or something like that, you know that it's just going to, as you're screwing the bone in, you purchase, it's going to back right off.
I get it. I get it. That is
so now
brilliant.
We have this bond of the silver and platinum in the same plane. So that way, when it's exposed to oxygen and fluid, you create the galvanic cell, creating it. And eventually, a few months later, you end up with a screw where the silver is gone and all you have is a platinum plated screw in place.
Will it still be antimicrobial at that point?
No, that's but at that point in time, you have bone growth around the bone screw and the plate. So it's during that crucial period of time during healing that you're at most risk of infection. So this is one of the other reasons when we developed our technology is that, again, silver builds up over time, and most companies or other competitors who have developed it over and played with it over the years, they measure the amount of silver they put onto a device in what they call micro inches. We end up measuring in angstroms. So we end up putting 10 to 15,000 angstroms of silver and platinum blend, a proprietary blend, onto the bone screw. And this also allows us to use the same coating for dental implants as well as plates and eventually other devices that are used within the body.
I assume you would if you had a plating system, whether it's wrist or ankle, you'd have the plates and the screws would be treated. Is that
That's the intent. The first one was we chose bone screws. And the main reason for that is if you think about a bone screw as an orthopedic surgeon, you're breaking through the cortical component of the bone, the cortical edge, and then you're entering into the cancellous area of the bone, seeding that with bacteria. Give you an example. You have a motorcycle patient. They're out on the weekend warrior. They go up, they crash their motorcycle. It's 2:00 in the afternoon. By the time they get into the hospital, by the time you stabilize them, by the time you've cut their leathers off, it's 3-4 hours later. Now you have road rash, you have bacteria that's in that area, and now you're going to spend almost all your time cleaning the wound before you go in and put plates or screws in. And now you put your plates and screws in, but the plate sits in the periosteum, and it sits in the soft area, soft tissue of the bone. So it sits on top of the bone. So as you give concurrent antibiotics, the antibiotics are bathing the plate because it sits on the outside. The screw, on the other hand, goes in, and that tip of the screw has now contaminated your cancellous area. So this is why we focused on bone screws initially. Plates will come after, but initially the biggest culprit for potential osteomyelitis is a bone screw.
So you've been approved for a study currently. Is that correct? Is it 510K, or what is the design of the study?
So that our product is a 510K, and that's critical because in this day and age, there's typically 3 different types of regulatory approvals that you can go for a device. Certainly, there's the PMA, which requires several years of follow-up, and it's a brand new classification of device, and you established, safe and effectiveness. And then there's what they call the de novo, which is it sits between the 510K and a PMA. And again, it's very similar to a PMA in the fact that you're a brand new classification, you're not establishing safe and effectiveness, but you are establishing that the product can be used within the body. We're a 510K, and we're piggybacking on some other technologies that have been out in the industry in the past. The benefit of that is that once we're approved, the product then can go to market, but it fits into the classification of bone screws. So all your DRGs and reimbursement and everything are tied to that classification. So this allows the product to be used immediately as opposed to being experimental for years later as you defend reimbursement. We are the very first product that I know of that was approved for a study in the United States. We have a non-inferiority study approved for 120 patients, and we're very excited about eventually getting it started and getting it off the ground, and we hope that we'll be rolling it out here in the first quarter of this year.
What are your inclusion factors you're looking for?
Again, we made this study a little bit different in the fact that it's a healing study. We're looking at, do we impact anything related to healing? So we will use a core laboratory that evaluates the healing from a radiographic point of view. The study will be 120 patients and will allow up to 1 to 2 comorbidities. So the study is going to be ankle fracture. But you take a patient who is diabetic and elderly and very susceptible to ankle fractures, then suddenly now we have a study that can be used that is relative to clinical practice today. So it's not a study that's going to be done in, ivory tower centers where you end up with the primo patients. These are patients who are going to represent the clinical practice. And we're approved for 10 centers, and we may, since there's been a shift to more and more surgery being done in ambulatory surgical centers, we'll probably end up using the majority of the surgery in the ambulatory centers.
I'm sure through our network, we can find you a few different centers, a few different surgeons.
We're very excited about that.
Yeah.
Hey, Paul, with the 510, once you've got it approved for the screws, could the process then be applied to other implants, or would you require additional studies like a pacemaker or rods, femur rod or something like that, nail?
So we did this years ago when St. Jude was still a company before they were acquired by Abbott. And I can fully disclose that we did a lot of work on not just the antimicrobial component of coating a pacemaker or defibrillator, but we were working with Intact Electronics. So they would send us a pacemaker or a defibrillator directly off the line. And then we would then coat the product. Well, now you have Intact Electronics inside of it. So you'd have to make sure that you don't cook the electronics during that process. So our process is we can control the temperature on that. Number 2 is in the case of a defibrillator, when it discharges, it completes the circuit by coming back to the can. Well, again, you have to not insulate the can. So we had to develop some novel striping methods to make sure that the can was still electrically active, and yet it worked quite well. And like I said, we can do it as the last step in the process. Currently, there's only one solution on the market, and it's a coated bag that uses both minocycline, I think it's minocycline, and rifampin. And the problem with that is it tends to get a little bit mushy, tends to get a little bit more complicated to move around the devices as you're working with leads. And so by coating the can directly, you can take it directly out of the box, put it in the patient, and you don't have to change the practice of orthopedics. And we have been very, very conscious of cost of goods. We've never wanted to develop a technology that was prohibitive from a pricing point of view. And so the pricing on our product is very inexpensive. So we've got that under control.
Can you be more specific about that? As my next question is, what does this add to the cost?
So our product is, you take a bone screw. I'll use a 4 millimeter by 10 millimeter bone screw. Typically in the marketplace today, the list price on those, and again, the list price from a lot of the companies are in the $350, $300+ range, but nobody pays $300 with contracts. They're all around the $100. But they make these bone screws for around $6 to $7 a piece. We add with sterilization. So our product is prepackaged sterile. With sterilization and packaging and the coating, about $3 or $4 a piece. So it will only increase it a small amount.
That's crazy good.
So when you think about it, when it comes down to making a choice, a 3.5 millimeter, 24 millimeter titanium screw that you're going to end up paying $120 for, or our product, we can almost price it at parity and maintain margins.
That's
at
crazy.
The current costing. Part of that is when you look at how we've set our team up here, I attribute that to our investors. So we have no professional investors in our company. Our investors are primarily clinicians throughout the world. And those investors keep us honest. The first thing they say is, anything that you develop, Paul, can't be a square dance. It can't be a change to how we practice medicine or how we practice surgery. So we can't soak it for 5 minutes and then we have to take it out and then you have to dry it, or you have to do, you can't add additional steps. So one, you take it out and you can use it. That's number one. Number two, it can't be cost prohibitive. And that is, if the standard pricing is $100, if you're thinking you're going to get 120, 125, it's not going to happen. So our investors have kept us honest and kept us focused to make sure that clinically whatever we develop can be used.
Let's talk about your study. So imagine, I know a particular surgeon, he uses a particular company for his ankle fractures. What does that look like? Are you reaching out to the company that provides that plating system to work with them? How's this going to happen?
So ideally, that would be the ideal situation. Certainly, we've talked to all the major players, and they understand that the market is in need. I just came back from Barcelona in October from the European Bone and Joint Infection Society meeting. It's such a big deal in Europe that they've actually created their own society, and it's focused just for orthopedics. And they're looking for a solution. The United States needs to lead the way and have a solution as well. So yes, we have been in conversation. It would be ideal to have an established bone screw, a brand of bone screws that are used on a regular basis, with a partnership in that regard. Otherwise, I end up getting bone screws from a supplier. Nobody knows who they are, and we launch the product, and that's a distinct possibility at this point in time.
Well, it seems like you'd be open to a lot of possibilities, and I wanted to talk about this a little bit further because it will determine like what type of introductions Jeff and I make for the company. Do you envision like licensing this to someone like Medtronic or Stryker, or how was that going to work? Obviously, you can't have individual relationships with all of these thousands of orthopedic surgeons and say, yeah, I want, Silver Bullet on my screws. It's got to be with the company, right?
Absolutely.
Would it be, Paul, and maybe this will change as you go forward, but like, do you envision multiple companies working with you guys, or having someone get like an exclusive opportunity,
The ideal situation would be for the company. Again, a lot of it is also contingent of based upon our patents. When we first started our company, when we were going out, the beauty about this is you can go to venture capital when you're starting a company, and you get $100,000 of free consulting in a half an hour on how many different ways you're not going to work. And the first one was, Paul, you realize, I have good ties to the venture community. You realize that silver's been around a long time. You're never going to get a patent. Well, 30 patents later, we've been pretty successful. And that patent allows us to carve up the clinical need. So you get a strategic orthopedic company that only wants that. They don't need to buy the rights or the IP related to cardiovascular. And then you talk to the cardiovascular companies, and they don't necessarily want dental. So right. It allows us to work with different clinical entities, companies, and work in that direction.
And it would seem like whatever orthopedic group got it, though, could corner the market, because as a physician and then a patient too, I wouldn't want a bone screw in me that doesn't have this on it, now that I know that it should be available, especially considering its marginal cost, right?
When you think about it, like I said before, it's you get a choice, and that is you can get this for $100 or this for $100, and this one has the extra features. And if you ever do get an infection, what will help drive a lot of the adoption in medicine today is that, and it's sad that it's driven this way, is that now, if you're an orthopedic surgeon and a product is approved on the market and you do get an infection and the patient doesn't feel that they were wronged, they get an attorney. And the attorney says, hey, why didn't you use this product?
Yeah.
Ignorance
Things work.
Ignorance is not a defense. If you say I didn't know it existed, doesn't work. If you say I didn't believe in it, it's not FDA cleared, but it is FDA cleared, then that's not a defense. So what will drive the adoption is that, even if you feel that you don't have a high infection rate. So there are orthopedic surgeons who, only operate on, the 20 to 24-year-old jock football players who are in great physical condition. And then there are the trauma surgeons who see everybody who walks in the door. Once they're draped off, they don't know who they are. And so in that case, that will give you that protection as well. And it gives the patient a protection. You bring up ankle fractures. I have two friends who are very active from a sports perspective. My best friend from first grade, he was the varsity soccer coach for the women's at the local high school up until about 5 years ago. And then 5 years ago, he was out camping, tripped on a rock, broke his ankle. By the time he got 2 miles back in and into the hospital, it was almost 24 hours later. They put the screws and the plates in, and yes, he developed an infection 2 weeks later.
Oh, wow.
And as a result, he can't run up and down the field anymore with his players. So now his first love in life of being a varsity coach for women's soccer is gone. He can't do that. So it does come back from a personal perspective. I mean, we know everybody. You've probably met people who, once they get an osteomyelitis too, a lot of them don't realize they're on medication for sometimes the rest of their life.
Yeah, so hard to treat.
Yeah, I think definitely trauma, open fractures, patients with multiple comorbidities, no doubt. And I think, I'm an orthopedic hand surgeon, and infections are just incredibly rare. I guess I'm blessed by the nature of my practice, but if this existed and it was available, of course I'd use it because I'd take the chance.
Well, there is another area that we're going to work on simultaneously, and that is external fixation. Well, external fixation, if you use your external fixation, which you probably do use in hand surgery, is external fixators and the pins tend to become infected almost 100% of the time, because now you have a environment to skin attachment, and the potential for those pins to become infected literally occur. So anybody on the lower extremity who puts external fixation in, the first one I've always laughed about, and yet it's kind of tragic, is they said, when we put these external fixation systems in, the first thing we say is a prayer, because we know the patient's coming back in a couple of weeks and I'm going to end up cleaning the wound.
Well, Paul, there was a really interesting slide in your deck that talked about the hierarchy of infection, where, and I've seen the whole spectrum, but can you speak to that? Initially, if you're unlucky enough to have a patient that gets an infection, you've got to deal with it, possibly remove the hardware, but then, it can cascade to a much worse situation.
Certainly. I mean, this is the way clinicians and the way we view the world, and that is, if you get an infection on a patient, it just costs a lot of money. Well, as you go up the hierarchy, it can go from the next step from an infection to now you actually have to go in, remove the hardware, and you talk about patients, debriding the wound, going in with a scoop and taking out infected tissue. It's incredibly painful and leads to potential disability. So ultimately, you'll end up with a potential malunion or malhealing. So now, instead of, when you got your goniometer out and you're lining everything up and you've got your proper, alignment, now you're not going to have your alignment anymore. So now you're going up the hierarchy, but it could get even worse. In the case of diabetic patients. I heard an incredible statistic one time about diabetics, and that is 6% of all diabetic patients have to deal with the prospect of an amputation at least once in their life.
That's sad.
Right?
I would
So
think it would
you
be
go
more
up
than
that, then you're dealing with amputation, and in an extreme case, you could have death.
Yeah, mortality.
And so that's how we look at the hierarchy of, at the lowest level, it's just going to cost the system a whole bunch of money. But as you go up, now it affects both the patient and it affects the clinician moving forward.
I'm glad you brought this up, Paul. This has affected me personally. My brother had a terrible ankle fracture about 5 years ago, and he has some comorbidities. He's overweight and some other things, and he had to get reoperated on. And it was not pretty. I mean, it was a 6-hour operation, and it was just a terrible break. And I just wish that this was available to be in him at the initial operation, because I think it would have changed the outcome.
Absolutely. So something as simple as, silver and platinum added to the device makes not just improves the lives of the patient, improves the lives of the orthopedic surgeon or the surgeon that's involved, and ultimately it saves money to the system. I mean, there's not too many that are true technologies like that.
Amen. Yeah, you look at those things and you think, God, there's got to be a better way. Well, here it is, silver bullet.
Yeah.
Hey,
No doubt.
hey, you touched on this already, Paul. Where are you? So you've got some approval in the EU, right?
Yes, correct.
What tell us and the listeners about FDA, where you are in the process with us here in the United States? Because I thought that was a good thing to talk about.
Yeah. So the FDA literally took 5 to 7 years to work with them on this. The orthopedics group, unlike the rest of FDA, does not have a lot of experience in the antimicrobial aspect in orthopedics and spine. And we made a good relationship. He is just retired, Dr. Bill Mazel, who is head of the CDRH. He formed a group at FDA Orthopedics and for us. And about 3-4 years ago, we were meeting almost once a week. And the once a week plan was they were learning from us antimicrobial in orthopedics, and we were learning from them on what's the process and how we would get through the FDA. This built a great relationship. We have a very nice relationship with the FDA. Something that wasn't necessarily on my bucket list in my life, but we've had, like I said, a first name basis. We've come to respect them. They've come to respect what we have. And so the amount of effort that went through on the review to get the study approved included everything down to how we manage the intra and inter quality control on how we coat our devices, down to what's the impurities when you coat your devices of all the other potentials, arsenic, cobalt, you name it, that can be in metals. And so the good news is we measured all that. And because, again, we're measuring things in the angstrom level, when you apply the multiplication, we're 1 in the 100 billion number of impurities. This is not necessarily true on other technologies. And I might actually throw in, we're not nanotechnology. Nanotechnology has been associated with increased genotoxicity, a recent study that was just published last year demonstrated significantly increased inflammatory response to nanotechnology. And the reason for that is most people think nano is small, but we're measuring things at the ion level. And when you compare the difference, a piece of nano silver is about 100,000 times bigger than a silver ion. So it's just a big chunk of silver, but small.
It reminds me of a funny story I've told a few times. I was interviewing at the med school to get in years ago, and I was interviewing with a Nobel Prize winner, Stanley Cohen, and he looked at my resume and said, physics major. And he hops up and he runs out into his lab, which was right behind me, and he comes back with this little piece of something. He says, "Can you tell me the process by which I could gold plate this?" And I knew the answer, but I thought I might throw this out at him. I said, "Dr. Cohen, we're in Nashville. They gold plate records here all the time. I think I can take it down to Lower Broad and get it gold plated this afternoon."
Well, you got in.
Right. Yeah,
Anyway.
that worked, didn't it?
No, Paul, are you in like a phase 2? You're about to go into phase 3 for FDA here. Where are you specifically?
Well, so our study is like I said, it's 120 patients scheduled for. We can go up to 10 centers. The compensation is going to be reasonable, and also it will give anybody who is part of this study publication rights. So when you think about it, to be the first to publish in this area would be significant. And so when you think about 120 ankle fractures, it should be a rapid enrollment because it's the most common fracture. And so with rapid enrollment and a 6 to 9 month follow-up, and again, part of the process of getting an IDE approved through the FDA is that they have to basically review all your other work prior to that. So all your biocompatibility, everything, because they're not going to approve something that can go into patients if they know that this is not an approvable product afterwards. So we've already got all the legwork done, and it's all documented, and it's all in the files. And so now it's just dependent upon proper clinical data. And because it's a non-inferiority study, all we have to demonstrate is that our complication and healing rates are not worse than what's currently on the market. So it could be as fast. I mean, the biggest challenge right now, and this is another reason why focusing on ambulatory surgical centers is great, is that a major teaching institution and working through their IRB often takes a little bit longer time. But with an ambulatory surgical center, you can end up going to a Western IRB or one of the major IRB centers and get it approved, and you can be up and running relatively quick.
I think we could get you 100 patients here. I don't think you need 10 centers.
A minimum of 3 surgeons that I'm thinking of, and 2 companies I think would actually be great because they're not the biggest, but I think they would be ideal at this phase.
Well, that's the other thing is, a lot of companies, I have a pretty strong background in sales and marketing. I had been the vice president of marketing at a couple companies, and I know what it takes to commercialize a technology, and it's not for the faint of heart. I mean, a lot of people think, okay, well, you built the company and you spent X, but if you make the wrong decision on your vice president of sales or you make the wrong decision on this person, it can stunt the company and set them back. And it's moving forward. Do I want to build an entire commercial infrastructure? Probably not. I mean, do I want to go and work with one of the 4 or 5 major strategic orthopedic players? Absolutely, because they've already got the infrastructure in place. They already know who the ideal surgeons would be to help jumpstart the commercialization efforts later on. Now, I'd love to be able to be going to AAOS 2026 with a partner and saying, we're in with FDA and we anticipate clearance within the next 30 days and laying it all out. That would be ideal.
How portable and reproducible is your ionization process? Is that something you could, if you had that big partner, would you install that at their place, at their manufacturing location? Yeah. Or
more than likely that's what we would do, because we've already been through that with the dental implant, and that is, do we take dental implants, and how would we take dental implants, and we can do anywhere between 500 to 1,000 implants because they're small, and coating in one run. So how would you get them from Switzerland here, coat them, put them back in a carrier, and send them back to Switzerland? I mean, it starts adding a lot of costs and a lot of other problems, and as a result, you try to minimize that, and so In Memphis, there is a lot of great orthopedics companies. And so if they put it in, they'll probably want it running right alongside everything else.
So once you've done this 100 ankle fractures, you're ready to commercialize. Is that accurate?
Well, we'll have to take the data, go
But
through
that's
it,
it. You get
and
clearance.
then submit the entire package back to the FDA.
So you're already revenue positive then with the dental implants and the stuff in Europe, right?
Pardon?
Revenue. You're revenue positive. If you're already cleared in Europe and you're already doing the dental implants, is that right?
Yes, we've already got the product is already approved in Europe, and we've held back a little bit on commercialization because, again, we'd ideally like to partner with a major company. I mean, we'd look for smaller distributors, and to be quite honest, the opportunity scared them. One of them specifically told me when they launched at the Orthopedic Society meeting last year for us, they came back and they said, so here's how we measure the market, Paul. We say that there's one bone screw used for every individual in the population. And if Europe has 100 million people, that means there's 100 million bone screws sold in all of Europe in a year. Even if we take the 2% and say you are going to only be used for high-risk patients, that's 1 million to 2 million screws a year that we'll end up using in Europe. At $100 a piece, we can't afford to support the accounts receivable on that.
That's a good way to look at it.
They said in Europe to collect from the hospitals $100 to $200 million would be painful. And so, wow, that was kind of a backhanded compliment, I guess. And that is, wow, you built a great technology, but almost too big for me. The recommendation, go and work with one of the major players.
Yeah.
Yep.
And I think for the sake of the study, a smaller player might work.
Yeah.
Am I wrong on that?
Absolutely. A smaller player would actually would not only work, but so if you take a smaller player in the orthopedic community, strategic, they live and die by bids or tenders to hospitals. And some of these tenders are, 2-3 years long. And so it's not uncommon for somebody to put their bone screws in as a tender and lose it because they're $2 off. Now you can go in and say, we have an entire antimicrobial bone screw system that nobody else has. That allows you to own that market, and you don't have competition. So you don't have to go up against, one of the major players and lose. So from a strategic point of view, there's a lot of value.
Absolutely. Paul, how does someone invest in this, say they're accredited, assuming they're accredited?
Yeah. So we have done, like I said, we have a great group of investors in our company. And as I mentioned, I'd probably say 80% of them are clinicians. We have yet to ever tell our story to an orthopedic surgeon or a clinician and have them say, that's not a very good idea. Why don't you go back and try something else? They all get it. 100%. I've yet to ever run into an orthopedic surgeon who said, this is not. So as a result, we end up with a very good group of clinical supporters and financial supporters. My recommendation is that I have an open round of funding right now that I'm running with our current investors. And I would just go back to the board and say that we're going to open it up to outsiders. And if they want to contact me directly, I will be happy to share the term.
Okay. And we can put all of that in the notes associated with the podcast.
Great. So with that, I mean, I think we've covered a lot of ground here.
Yeah.
I hope we've covered a lot of ground.
Yeah. Is there anything else you think we should hit on? I mean, we've talked about the investment opportunity, what it does clinically, your contact information we can post with the video. And if you're watching our podcast, they know how to reach us. I think we just start making introductions for you, Paul.
No, we're really excited about your professionalism. We're really excited about your point of view. So we look forward to that. We are a very flat company. We have no hidden agendas. And the only agenda that everybody lives by in this company is that someday when we're all retired and we're sitting there and we pick up the Wall Street Journal and we read about this company announcing a new coated product with our coating on it that's going to clinically save this many lives a year.
Yeah.
That believe it or not, that drives us. And so obviously the investors would like to get a return, but they're not asking for an astronomical return. And so as a result, they are all driven by, we just want to see this being used on a daily basis on patients.
So nice to hear. We strive to have guests on the show that help physicians do their job, help patients clinically, and then at least have the potential to enrich us financially. And Silver Bullet checkmarks all the boxes. Paul, CEO of Silver Bullet, thanks for joining us. This has been a pleasure. It's going to really be something I'm going to look at myself personally to invest. I'm glad you've asked Jeff and I both to join the advisory board. We're honored, and we're going to help you however we can. I'm Dr. Jeff Brown with my co-host, Dr. Jeff Cole with Silver Bullet. That's
Thank you
awesome.
very much.